And we're so fortunate to have it. I'm going to turn the meeting over to Dr. Giessell. Thank you.
I thought I'd speak without a microphone if everyone can hear me in the back. My voice okay? Okay. And Russell asked me to talk about emphysema, tobacco, and COPD. And I kind of thought about, well, what am I going to say and how am I going to say it? And I decided, well, about half the audience have been my patients or my partner's patients or I've seen in some way or another. So I thought I'd just sort of talk as I would to a new patient who comes into my office with COPD and talk about some of the things I would usually discuss with them, both with regards to the disease, what causes it, what they can do about it, with kind of a focus on the tobacco issue, since that was in the title of my talk. I thought I need to kind of focus on that. But if I start talking about stuff and you want to go in a different direction, that's fine, because that's what happens in my office. I start on my spiel, and the patient's got other issues that they want to talk about. So if you guys have other issues you want me to talk about, us to talk about together, that's okay. And so we'll see where it leads. So some of the things I say, many of you will already know, but there may be some newcomers and people who don't know much about COPD. So if I talk too low for some of you, well, tough luck. And but I want to try and make sure I speak to every member of the audience. So what is COPD? We have traditionally divided it into two groups, if you will, and it's a little bit of an artificial division, but it's useful. And the two groups that we sometimes think about are emphysema and chronic bronchitis. Well, what do I mean by that? Emphysema is a disease, the visual concept I give to patients is, if you think of a sponge, a normal sponge, that's what a normal lung kind of looks and feels like. And you imagine soaking that same sponge in some acid so that it starts to dissolve away over time. And you have that sort of visual image of what that would look and feel like. That's sort of what emphysema is, where the stuff of the sponge, the stuff of the lung, dissolves away slowly, slowly over time, so you're left with sort of a loose, baggy, flimsy sort of thing. So that's kind of a visual image of emphysema. Chronic bronchitis is a disease where the tubes to your lungs, the bronchi, start secreting more mucus and they get clogged up. So you get problems with cough, mucus. Because these tubes are clogged up and air can't flow through there easily, you get short of breath. So that's chronic bronchitis. We have a couple of colorful names that you may have heard over the years that apply to these two somewhat distinct entities that really kind of overlap. That of a pink puffer, pink because their oxygen level is okay, puffer because they're short of breath. And that would be sort of the classic emphysema patient. And someone was asking me earlier, and it's a question I'm asked 100 times a week, it seems like, well, why am I short of breath even though my oxygen level is okay? Well, those two things don't always match up. You can be very short of breath with a normal oxygen level. You can have a very low oxygen level and be not short of breath at all. So the two don't always match up. And the pink puffer is kind of the classic way we think of someone who has emphysema, this sort of baggy, flimsy lung that is short of breath, but oftentimes doesn't have a low oxygen level until much later in their course. And the chronic bronchitis patient is someone who will tend to have more cough and mucus, will tend to have a low oxygen level, but might not be so short of breath. So you're kind of surprised, well, gee, your oxygen level is terrible. Well, doc, I feel fine. I'm not short of breath, but your oxygen level's up. I feel fine. So that sort of discussion often in the office. And I've sort of painted these two pictures, but there's no patient, or very few patients, that fit that stereotype, and there's kind of a merging of the two. But it's a useful way to think about these two aspects of COPD. Well, what causes COPD? Well, about 80 to 90% of COPD is caused by tobacco smoke. It's not the only cause. There are other causes, most of which you can't do a whole lot about, like who your parents are. You know, it's usually too late to change that by the time you find out you have COPD. By which I mean there is a genetic tendency towards lung disease, so that some families, some patients are more likely to develop COPD just because of their genetic makeup. There are other exposures, cotton dust, other organic substances that can lead to destruction and damage to lungs and COPD. But the number 1, 2, and 3 cause is cigarette smoke, 80–90% of the time. Well, how does tobacco do this? Well, one way it does this is by serving as an irritant to the airways, so that you're inhaling all this smoke, which the lungs don't like, and they see it as a foreign substance because it is. And the response is for the glands, the mucus glands in your lungs, to start producing more mucus, more mucus, more mucus, to try and fight this foreign substance that it's being exposed to. And that leads to mucus hypersecretion, would be kind of the fancy word we use, and would show up as cough, producing a lot of sputum all the time, and kind of is that chronic bronchitis part of things that I described a few minutes ago. The other thing that happens is some of the chemicals in cigarettes start to dissolve the lungs, and we now think that there's this sort of balance in your lungs of chemicals that can dissolve things, proteolysis is the word we use, and other chemicals that work against that. And one of those chemicals, as you may know, is alpha-1 antitrypsin. I don't know, did y'all talk about that in this meeting? Anyone familiar with that?
It's in the brochure.
We have talked about it.
Yeah?
And we're going to be testing it again this October with this flu shot.
Okay. So, you know, that's a chemical that occurs naturally. Some patients are deficient in, and so they're much, much more likely to develop emphysema and COPD because they lack this sort of counterbalancing chemical that helps to prevent dissolution and dissolving of the lung. So that's what causes COPD. And as you smoke and you develop this process gradually over the years, you start to lose lung function. And oftentimes, patients will come in to see me and say they don't understand this because a year ago they were fine, they were doing what they wanted to, but in the last 6 months I've just gone downhill. It couldn't have happened this quick. Something dreadful must have happened to trigger this. But no. What happens is as you lose lung function, you don't have any symptoms. It's sort of like the gas tank on your car, and I apologize if some of my patients have heard this metaphor before, but I'm going to use it again. So if you have a half a tank of gas, you're doing fine, right? Quarter of a tank, sailing down the road, 1/10 of a tank, no problem, empty, big problem. So that overstates the case to make the point. So as you lose lung function, you have no symptoms, and then you get down there to eat, then you got a big problem. And that's because we're all born with more than we need. And we can afford to lose some lung function, and have no problem. So as you lose lung function, you might miss a year if you're an Olympic athlete. You might have to get down that low to miss it if you do heavy manual labor. You might have to get down really low to miss it if you're a relatively sedentary individual. But once you get down to that critical level, small changes make a big difference. Not much difference between a full tank and 3/4 of a tank. Big difference between a quarter of a tank and empty. Okay? So as people lose that last critical bit, that's where they go from being fully functional, having no problems, to over a short period of time, having a lot of problems. Now, if you think about it, what if you were to put that in reverse? If losing a little bit makes a difference. Wouldn't gaining a little bit make a big difference too? And yeah, I think it does. The problem is how you get that little bit back. And the way you get that little bit back is if you smoke, stop smoking. If you smoke, stop smoking. If you stop smoking, stop smoking. So, you know, that's more important than all the drugs and medicines we give people. And when people stop smoking, they don't immediately go back up to where they would have been if they never smoked. They will never go back there. They get a little bump up. But just like that small drop makes a big difference, a small little bump up also makes a big difference in a positive sense in terms of being able to breathe better and being more functional. The other things you can do, of course, some of the bronchodilators that help open up your airways and let air get in and out easier. And those of you who have COPD are undoubtedly on one or more of those medications. And I'm not going to plan on talking about all those, but I dare say there'll probably be some questions about them in a minute. So, if you smoke, what can you do about it? I don't know if there are any smokers in this audience. Perhaps there are. If not, then you perhaps know individuals who do smoke. And since I said I'd start off kind of talking like I would to patients who come into the office, and most of my patients smoke or just quit smoking recently, I'm going to talk a little bit about what you can do to stop smoking. And the people in this room who used to smoke and now don't may have some stories to tell on what worked for them. The number one way to stop smoking, you got to want to stop smoking. Doesn't matter if your doctor wants you to stop, your wife wants you to stop, your husband wants you to stop, your kid, you got to want to stop. And so when I see a patient with COPD and I ask them, do you smoke? And if they say yes, the next question I will invariably ask is, do you want to stop? And the response tells me a lot. If there's a long pause and they say, well, it would be nice, we ain't going to get there. You know, they've got to want to stop. If they respond, I want to stop, it's just hard, then we've got a chance. So the number one way to stop smoking is to want to stop, and that's got to come from inside you.